Good evening, friends. On behalf of the governing committee, the patrons, and all the members of KAHO, it's my proud privilege as Secretary General to welcome all of you to this very important introductory webinar on NABH Standards 5th edition to 6th edition. It's indeed a very important day for us as we go through the standards. NABH is the connecting factor that's been the most important factor that has brought us all together. I think it has done wonders in this country by promoting quality and patient safety. And we are delighted to have with us two important people, stalwarts in the field, Colonel Dr. Sunil Rao and Air Marshal Dr. Pawan Kapoor. So they are going to be bringing to us the major changes that have taken place from 5th edition to 6th edition. And it's amazing to see the response from across the country. Sirs, we have more than 2,200 participants who have registered from all over the country, different hospitals, and that shows the length and depth to which NABH has actually penetrated. So thanks to all of you for joining, and for our patrons, for our members, for the kind of support that you give to KAHO. I hand over now to Colonel Dr. Sunil Rao. He needs no introduction. Dr. Rao, the architect of the 6th edition, I must say, the chair of the technical committee of NABH for the 6th edition. He's the group COO and director medical services for the Sayadri Group of Hospitals Private Limited. He's very, very passionate about what he does, a great leader, an excellent team player, and I was privileged to work with him in the 6th edition as a member of the technical committee. Over to Colonel Sunil Rao to take the proceedings forward. Thank you so much, sir.
Thank you, madam, and a very good evening to all of you across India, 2,200 people, as Madam Lalu said. So here I am today on behalf of NABH. Also, I want to thank this forum, especially because it is through them this edition is coming forth to all the public, as well as the hospitals and healthcare organization. So essentially, I won't take much time. Today, you are going to hear what are the changes which have been made from 5th edition to 6th edition by my mentor, Air Marshal Pawan Kapoor sir, who is very well known in quality circles, again, because he's been the founder member of this NABH, as well as many other organizations associated with the quality, including, I think, KAHO also. He has been associated since a very long time. And he has been guiding us throughout our journey of change from 5th edition to 6th edition. There are many path-breaking changes, I would say, keeping in mind the contemporary environment of this country as well as the entire world. And as you are already aware, I would again like to repeat that ISQA has accredited these standards without any observations. That is a great credit to all of you, as well as to NABH, which came out with flying colors in terms of the changes, which truly prove that it is contemporary and keeping in view the time changes have been made. I would like to only mention few changes which Air Marshal Pawan Kapoor sir is also going to highlight. This is first and foremost, I would say, that environment, sustainability, and the governance, which is on these three pillars of environmental changes, then sustainability of the healthcare organizations, and the governance changes which are needed to remain contemporary and remain sustainable. So this is one major change which has been made. Other concept of continuum of healthcare, that means it starts from preventive, promotive, curative, rehabilitative, spiritual, and many other contours of the healthcare, which have been brought out very nicely in this 6th edition. Also, some of the things which are part of the continuum, like home healthcare or domiciliary care, what we call, Another aspect of it is adolescent care, which is again added. So the entire spectrum of healthcare has been made complete through these addition changes, which is also given appropriate examples and annexure. Another very major change to improve our association with the clinicians and the clinical field. The clinical indicators, which are department specific, have been added. That was our wish when we started forming these standards, these changes, that all the clinicians, that means each and every department, sub department, must get involved into change process of what is happening in the world. So that is why these indicators, which are department specific indicators, have been introduced, and many more specific changes in each and every chapter, including change in the name of the chapter itself, which gives us the prevention aspect of infection control. So the prevention aspect has been included in the chapter itself. Air Marshal Pawan Kapoor is the right person. He has been a Director General Armed Forces, Armed Force, Air Force, Director General Medical Services Air Force. He is also the technical advisor to Rusocon, apart from his previous appointment of Vice Chairman. Now he's a technical advisor to Russo Education after leaving Armed Forces. So, and he has been mentor to me throughout my Armed Forces career also, and he's truly, I would say that quality as well as patient safety defined, and he's the messiah, I would say, in terms of formation of any standards for that matter. And he's been active part of ISQA also, which also is our base for these particular standards. So without wasting much time, I think I will hand over to Air Marshal Pawan Kapoor sir, and I would request him to take it forward. Thank you very much.
Thank you, Colonel Sunil, for that gracious introduction. I'll just share my slides. Okay, good evening, everyone, and nice to see so many of you joining this webinar, this introductory webinar on changing changes in 6th edition. So before I actually begin, I must communicate my thanks to several people. And those thanks are there because not only these standards are there because of them, but also there are many people who worked around the clock to get this standard, the type of grading that this standard has got at the hands of ISQA. So first and foremost, I must thank KAHO for giving this opportunity to all of us to share what have been the major changes and salient changes in these standards. The second is my thanks are also due to the technical committee chaired by Colonel Dr. Sunil Rao, and with Dr. Lalu Joseph being one of the members of the TC, with Dr. Sanjeev Singh and many others who have contributed to the formation of this standard. They have put in a lot of efforts, but they have been very, very practical in their approach. While they took feedback from all stakeholders, they ensured that the 5th edition standard, which is yet to be completely imbibed by the environment, does not undergo a major overhauling. Rather, they continue with what is contemporary and what leads to continual quality improvement in the standards itself. So I must thank the technical committee for their hard work, for the consistent deliberations, thinking out, taking out time to listen to all the stakeholders and putting in hours and hours of work together to come to consensus on the various changes that have been made. And it is largely due to their efforts that when we filed in the ISQA self-assessment toolkit, we realized that we have almost met all the requirements, and that was when it was assessed. There was no recommendation. That means everything was in order, save for a couple of opportunities for further improvement. They have given no recommendation, which is probably, in my experience, being an ISQA assessor for the last almost 13 years, it has very rarely happened. So, a lot of kudos to NABH and to Colonel S.K.M. Rao also. I must thank the NABH Secretariat, the CEO of NABH, and the SGO Quality Council of India, who have been always partners in this journey. And they also want that the NABH should reach to the last man in this country. Not only this, we also got a NABH international arm, which is also gaining grounds over a period of time, and they are finding that our standards are very, very useful to them to both implement, and they are not that complicated. So a huge round of, a huge amount of thanks to NABH and its team. And of course, to all of you who have been partners with the NABH for such a long time and who have been members of KAHO, without whose support and feedback, this particular edition would not have been possible. And if I miss somebody, I will probably thank a bit later. So I must thank, of course, Dr. Meenakshi, who has been instrumental in helping me out with this presentation. It is never easy to bring in together in 1 hour all the salient changes, but she has been very supportive and she has been working late till yesterday evening to bring her portions together and send it to me. So thank you, Meenakshi and Chaos Secretariat, for all the support. So let's straight away go into this, and I'll start with good news. It is always good to start with good news. There is no change in the total number of standards. They remain 100. The total number of objective elements have been reduced from 651 to 639, and there is no change in the scoring. So that all these things have not been done with a view to ensure there is continuity in implementation of the 5th edition. Then with every good news, there is bad news. And the bad news is that we still have to implement it within specified time periods. And NABH has stated very clearly that from 1st of January, any fresh applicant will be based upon the 6th edition. All reassessments or re-accreditation will be carried out as per the 6th edition. That means you have to achieve the excellence standards, and all surveillance will be till 31st March. You have to be prepared, and after 31st March, all surveillance assessment will be as per the 6th edition. So you have to implement these standards within these specified time periods. Before you go to the changes, what has not changed? The focus of the standards have not changed. And in the focus of our standards have always been patient safety. In this case, patient safety has been further augmented by making safe practices reach to the home by augmenting patient engagement in care. They have also augmented the employee safety by ensuring that the second victim of an adverse event is taken care of, and by addressing violence at workplace, which has been of national importance in the last couple of years. They have again focused on community safety by prescribing to sustainable development and therefore also reducing the carbon print in the country. They have focused on environment safety. They've also focused on community safety by promoting and introducing preventive measures for healthcare. And of course, the process is on for continual quality improvement by bringing the focus of the standards also on the department so that there are clinical indicators for each department. The classification of objective elements has not changed. It remains the same as commitment, core, achievement, and excellence. The structure of this NABH guidebook has not changed. There is a small write-up on NABH on the scope and purpose of the standards, the overview of the process, how to read the standards, what system documentation guidelines are still remaining the same, the scoring remains the same, the decision criteria for accreditation have not changed, and the summary of changes and abbreviation that remain in this order in the revised 6th edition. Same thing, the chapter headings are there, the intent followed by summary of the standards, the description of the standard, the objective elements to determine the compliance with the standards, the interpretation part of it, the references, they have not changed. The naming, that chapter wise with the AAC.1.E. that has naming and numbering have remained the same, and the glossary has changed little bit to include new terminologies. Now, what was the basis of making changes? The first basis is that there is a score requirement that every 4 years, the standards have to be reviewed based upon feedback received from the stakeholders to address the needs of the stakeholders, and those revised standards have to be submitted to ISQA for re-evaluation. So this is one of the requirements of ISQA. The primary purpose is to raise the bar and have continual quality improvement in the quality of standards and remove any ambiguities, any difficulties or inconsistency in interpretations, and also to follow what ISQA calls the Ramba principles. That is, are your standards still relevant? Are they contemporary or not to the current governance? Are they understandable to the stakeholders? Can they be measured easily? Are they beneficial in implementation? And are they easy to implement? That is achievement. So based upon this, the changes have been made by the technical committee. And of course, the technical committee was very clear. They knew that सारे के सारे bulb नहीं बदलने हैं, only important aspects. So they have accordingly done that. It is not old wine in new bottle, but it is old come new wine in a new bottle. Now what has changed? Of course, the language has again become more English, that is more simplified. More clarity has been brought in interpretation. We will see as we go ahead. And there is greater emphasis on implementation. The word earlier on we used to use should, will, would, shall. Now they have become very clear. They have used the ISO standards that we must use only shall, and should, will, would has been done away with, and it has very clearly stated that shall will be the mandatory requirement. Whenever the word shall is there, that has to be met. If it is not met, it will result in a non-compliance. Can and could have maintained the same meaning as was done earlier. That means they are not to be listed as NCs or considered for scoring. They can be opportunities for improvement. So what do we write? Can and could, they are opportunities for improvement. They are not non-compliances. And adequate and appropriate is not, there is no specific interpretation. While the amount of objective elements with adequate and appropriateness has been reduced, but they continue to find their mention in the standard, in the objective elements, and this is based upon best practices and evidences. So whether it is adequate or appropriate, where you cannot quantify, then you have to qualify based upon best practices. Now some example I am giving you of interpretation, like if you see COP2D, which was earlier COP2E, it has stated trials shall be done. This is correct, it is maintained. But earlier it was said that trials shall or should be part of the routine day-to-day functioning of the emergency department. Should has been removed and replaced by shall. The criteria could be separate for trauma and non-trauma patients and adults and children. That could has been maintained. But here it has been further amplified. For example, for pediatric assessment triangle or pediatric observation priority score can be used for triaging of children, and they've also included as an explanation to make sure that everybody understand the intent of this objective element, that if several clients are waiting to be triaged, then it is not possible to apply physiological parameters on each and every client. A visual assessment can be conducted or may be conducted. So they're giving you that leeway also. Now, if you come to the total number of standards and objective elements, thankfully, chapters and standard number have remained the same and objective elements have been reduced. And as brought out by Colonel Rao, chapter on HIC has been renamed as Infection Prevention and Control, because hospital infection control was not actually alluding to the word prevention. So this word has been included in line and in tune with the best practices elsewhere. The classification of objective elements have remained the same, but the number of objective elements have changed. In final assessment, the commitment have been from 459, they've been brought down to 457, but the core objective elements have been increased from 102 to 105. The achievement objective elements, there has been no change in the number, they remain 60, but yes, some of them achievement have become core and commitment. And some of the excellence which have been reduced from 30 to 17 has been converted into achievement, and some odd ones have been converted directly to commitment based upon its importance and its relevance. So if you see this, in the 5th edition, there were 459 commitment. In the 6th edition, there were 457. The core were 102. In the 6th edition, it is 105. So now when you come for final assessment for the first time, the total number of objective elements actually have increased from 561 to 562. At the surveillance assessment, the achievement number standards of objective elements have not changed. They become from they are 621 earlier, they are 622 now. But a major change has happened at the re-accreditation where excellence level has gone down and they have been reduced from 30 to 17. And therefore, re-accreditation, when you come for the second time, you will not be assessed on 651 but on 639 objective elements. If you see this in ASC chapter, the objective elements have been, the standards have been reduced from 14 to 13. Rather, almost everywhere in the patient-centric chapters, the total number of objective elements have been reduced in all the chapters. If you see this column, they have been reduced in all the chapters, and one standard has been reduced from 14 to 13 in ASC. And the reason for this is because the standards on quality assurance and safety of lab and radio imaging services have been merged into one. And one additional new standard has been added, which I will refer to a bit later. In management of medication, there has been no change in number of standards and objective elements. They remain the same. If you see, the total in 5th edition was 61 in patient-centric chapters and 405 objective elements, but in the 6th edition, there are 60 standards and 392 objective elements. Similarly, in the organization-centric standards, you will find that most of the standards are reduced except in case of IMS, where one objective element has been added, and in case of ROM, one standard has been added, and therefore objective elements have also increased to 37. Now here more emphasis being laid on responsibilities of management and also some aspects of information management system that is related to digital technology and cyber security. Otherwise, by and large, they remain the same. Here also, HRM has not changed at all in the number. Although objective elements have been added, new objective elements have been added, and some have been merged. So total standards as per 5th edition were 39 and 256. In 6th edition, it is 40 and 247. Now, 2 new standards have been added. 7 partially modified objective elements are there, and there are 14 new objective elements that have been added in the 6th edition. Now, these are important to understand. It is not that they did it deliberately, that 2 into 7 is equal to 14. It just happened as a matter of coincidence. So you can easily remember 2 new standards have been added, 7 partially objective elements have been modified, and 14 new objective elements have been added to the existing standards. They do not include the new objective elements that have been added to the new standards. So let us see what are the new standards. There are 2 new standards. They relate to AAC 11 and they relate to ROM 3. So we'll see AAC 11 has added a new standard on preventive and promotive aspects of healthcare services, which are required to be provided in a safe, collaborative, and consistent manner. And this has therefore included written guidance on what is preventive and promotive care as per the scope of services. They need to be evidence-based and need to address even non-communicable diseases as well as age-appropriate screening for non-communicable diseases. They also include mental health screening and appropriate intervention is advised for patients wherever it is applicable. And they should also take into consideration both pediatric and adult immunization, which should be again evidence-based and advised wherever applicable. And a multidisciplinary approach is adopted in imparting health education on lifestyle modification. So these address the preventive and promotive aspects of healthcare delivery, which were Some were indirectly mentioned in the earlier standards, but this time they made it very categorical, and this is in context with the National Health Program's implementation. So the word wherever applicable is added here so that assessors and organizations do not misinterpret it. There are times when they are not applicable, so those cases you do not make it applicable. That is the word wherever applicable has been added in C and D. Now the next standard which has changed is responsibility of management 3. Here the sustainability has been brought into focus, which is a contemporary requirement. And there the sustainability will be focusing on environment sustainability, social sustainability, economic sustainability, and for long-term well-being of both the healthcare delivery system and the community which the system serves. So they have got environment, social, and governance responsibility for addressing the organization sustainability program. They've included energy efficient and environmental friendly initiatives with regard to a particular healthcare organization. They've also addressed the social responsibility. The staff well-being is promoted, has been included from HRM 9A, it has been shifted to ROM as a separate objective element. And at the level of excellence, the organization requires to follow sustainable procurement practices. All these have been amply explained in the interpretation of these objective elements. Then there are two at the level of achievement. See, the earlier ones were all at the level of A to D were all at the level of commitment. E is excellence and 2 are for achievement. That is the level of surveillance. Hospitals should encourage employees to use common or public transportation to reduce the achievement impact of commuting and carbon footprint. That is our contribution of NABH and hospitals' contribution that they should not contribute to enlarged carbon in the environment. And the organization should ensure financial sustainability of the hospital by balancing the financial aspects of healthcare delivery. So these two have been included. So far, we were only focusing on financial aspects as related to the investments in terms of quality program and in terms of the infection control program. But now this financial sustainability aspect has also been included at the level of surveillance. So these were the new standards. Now let us see what are the partially modified objective elements. So there are 7 partially modified objective elements. These are COP 8, B, C, and D have been modified to make the transfusion services more safe and make it more clear both to the healthcare organization and to the assessor what actually depicts a safe blood transfusion. So it is COP 8B, which was earlier on said transfusion of blood and blood component is done safely. Now here they have elaborated in a the interpretation contains clearly everything that is required in this standard. In this objective element, it states organizations shall establish and implement processes for blood component collection, testing, storage, and distribution under written guidance. What all should written guidance include is all given in the interpretation of this particular objective element. So this is further elaborating on this transfusion of blood and blood component is done safely. They have elaborated upon this. Second one was COP 8C was earlier blood and blood components are used rationally. Now this part has been changed to blood and components are stored safely from the time of collection till transfusion. So they are focused on storage of blood, whereas this rational use has come into COP 8D. That is, the organization ensures safe and rational use of blood and blood components. This was earlier informed consent is obtained for transfusion of blood and blood components. This has been taken to PRE in the informed consent. The entire interpretation has been taken to PRE to do away with the redundancy and duplication. Now, COP 10, which dealt with safe obstetric care, they had 7 objective elements. Now they have got 11 objective elements. Now, 3 objective elements have been added to ensure that the department provides safe obstetric care, which is based upon the Ministry of Health and Family Welfare Lakshya Guidelines of 2017. And that means we are also a part of the Ministry of Health and Family Welfare implementation programs. And one addresses what was missing is the artificial reproductive technology. So here at the level of achievement, we have given that organization encourages and welcomes the presence of birth companion during labor. COP10F, organization treats both pregnant women and her companion in a very respectful and cordial manner and ensures privacy and confidentiality of the pregnant woman during her stay in the healthcare organization. It also includes the treating doctor explains danger signs and important care activities to pregnant woman and her companion. Basically, it is an elaboration, all these are an elaboration of safe obstetric care. So therefore, we call them as partially modified objective elements to give more credence to safe obstetric care in lines with the Lakshya guideline. A separate standard has been added that the organization adheres to the legal and statutory requirements and defined artificial reproductive technology practices. That is COP10K. So all in all, there are 7 objective elements which have been partially modified to lend more credence to the standard. Now there are about 14 new objective elements. These are related to the lab. 1 ASG 7C, lab participates in proficiency testing and external quality assurance scheme. So what they have done is that what they have tried to now streamline what is external quality assessment, what is proficiency testing. This is the interpretation which has been used there, that based upon EQN and the proficiency testing evaluation report, the lab shall implement and document corrective action for the outliers. Sometimes this is not possible, and what are the reasons for which they are not possible? Like there is non-availability of a formal national proficiency testing program for NIHs of interest. There are only few labs performing those tests, or analyte to be measured is unstable like G6PD, blood gases and ammonia. Control material of the same matrix is not available. Under these circumstances, we cannot do. Then in that cases, the lab can adopt any other alternate approaches to validate performance by peer review or by any other means which the lab feels that it can validate their performance and improve quality assurance. So this exception has also been included into this. The next one is the care shall be provided by expanding access to health practice domiciliary visits wherever applicable. Now, if you read the definition of hospital given by the World Health Organization, the World Health Organization has very clearly stated a definition which was given decades ago. I grew up learning with this definition, and it defines hospital as a medical social organization, the purpose of which is to provide preventive, promotive, curative, and rehabilitative care to the community and whose services reach out to the patient in their home environment. That means WHO has been advocating the healthcare organization should be able to reach out in the home environment almost about 3 to 4 decades back. So this standard has now addressed that requirement of WHO definition of a hospital. Of course, in addition to the definition, they said the hospital should be also a center for training, education, and biosocial research. So to address this domiciliary requirements, the standard says that should be trained healthcare workers wherever applicable. Again, the word is wherever applicable. They should visit the patients to provide medical care, treatment, and support, and address the unique needs and concerns of these patients in their home environment. Any chronic conditions, fall prevention, memory care, nutrition, physical exercises, rehabilitation, physiotherapy, and for palliative patients, home visit is done to change catheters and or to provide additional supportive care. So this has been amplified in the interpretation of this objective element. The next objective element, which is COP11H, which is again at the excellence level, that the organization provides for adolescent-friendly healthcare services. So what Dr. Rao mentioned earlier, the need-based preventive curative and counseling services for adolescents. So we have not this important part, and lot of India has got a lot of adolescents. So these important aspects have been covered here for adolescent care. Here again, confidentiality shall be maintained in consultation, counseling, and follow-up. And they are given how it can be organized for managing physical and mental disorders, for premarital counseling, substance abuse, use of helmets while driving two-wheelers, preventive health checkups and wellness programs, immunization, for example, vaccine against HPV. So all these have been included in this. This is at the level of excellence. Again, at the level of excellence, they have included that the now patient should be involved in PRE 5J. The patient needs to be involved in enhancing clinical outcome, safety, and quality. This has gone a step forward in engaging patients. They could be disease-based patient support groups or involving patient in patient safety in the organization and quality improvement activities of the organization. You have to create, and they requires you to create an enabling environment. It's said here very clearly, shall create an enabling environment for partnership between patient, families, communities, and healthcare providers. Patients shall be encouraged to become actively involved in reporting safety incidents, near misses, and safety concerns. Rather, they should be a part of the incident management system, actually speaking, so that they can be more contributory towards preventing those safety incidents from occurring in the future. Formation of patient advisory council in hospitals is recommended as part of patient engagement. The organization required to recognize that patients are part of social group, families, and communities, and these broader networks can serve as a force multiplier for change. And the organization must designate and support patient safety champions or advocates to facilitate patient engagement. Another at the level of excellence is the quality assurance program should focus in PSQ 2D, that quality assurance program of an organization should focus on appropriateness of clinical care. And this appropriateness of clinical care has been further elaborated by saying that doctors and nurses should participate in utilization reviews that includes appropriateness of the length of stay. It could be diagnostic related, it could be average length of stay, it could be department wise. All this is left to the organization. On the appropriateness of the procedures conducted, on the appropriateness of the investigation and treatment. Again, at the level of achievement, PSQ 4B, the quality improvement projects shall include improvements in patient care delivery and hospital operations, which will have an impact on cost and efficiency. So here now they redefine that quality improvement project shall be centered on the 6 domains of healthcare quality. These are the 6 dimensions which have been laid down by the WHO. And they say this first one deals with safety and sustainability. T deals with timeliness. E deals with efficiency, effectiveness, equity, and patient and population centric. So all your quality improvement projects should be focused on these dimensions and domains of healthcare quality. So they're given a guideline. People are confused. How should a quality improvement project be put into assessment by the assessing team? So they're given the dimensions which can be utilized. That this is safe, this is patient centric. You can utilize those as quality improvement projects. Then RMM 1G, those responsible for governance shall develop clinical governance framework. So now clinical governance framework has been highlighted here, which comprises of patient safety, medication safety, clinical audits, clinical pathways, clinical indicators, education and research. Leaders of clinical departments should select and implement clinical practice guidelines, care pathways, and or clinical protocols to guide clinical care. And department leaders should encourage clinical audits, education and research. So all these is there to improve the clinical governance framework, getting more clinicians involved into the process of quality. Then FMS 3A is basically to address the security of all people in the staff and in different areas. Okay, so they need to have extra security. So operation planning should identify those areas and describe access to those areas. So this should be in the form of a manual to maintain security of patients, visitors, staff, and materials. It should include the planning process by identifying the various categories of people in the hospital, shall define access to different areas for defined categories, and should get details of access to OTs, ICUs, including NICU, labor room, and emergency room. Vulnerable areas where people can be actually, they can be subject to some violence, like dark areas, long corridors, entrances to clinical areas. They need to be identified and appropriate security to be put in place, such as CCTV coverage, and they should include all staff, patient, and visitors in the hospital. The next one is this technical committee has done one good job. There were a lot of confusion pertaining to fire and non-fire emergency, and they used to get clubbed. Here they have separated fire and non-fire emergency. So they have now stated the organization should have plan and provision for identification and management of non-fire emergency. They have identified all the type of fire and non-fire emergencies, and they have also stated that they should establish liaison with civil and police authorities and the fire brigade as required, and follow the guidelines given by the local statutory bodies in case of whenever you have got any such fire or non-fire emergencies. So guidelines given by the National Disaster, State Disaster, and District Disaster Management Authority should also be referred to when you have to provide for prevention and taking corrective action in cases of non-fire emergencies. Then HRM 3J has included training on information systems, information security, information use and management, which was not there earlier. Since we are going into IMS with digital technology, so people should be trained for handling these responsibilities on these systems. Therefore, their job responsibility, job descriptions, and data information needs must be identified, and they must be trained on this. And if they are using electronic medical record, then all staff should be trained on the use of that electronic medical record. HRM 9 Alpha, health problems of staff, including occupational health hazards, are taken care of in accordance with the organization policy. So there has to be a written guidance on staff health and safety. More importantly, all these aspects are normally to be in consonance with the law of the land. But what is important here, which has been brought out as another matter of importance to us, is to support the second victim, that is those staff who are involved in unanticipated adverse events, medical error, or patient-related injury. Normally, we are in the habit of blaming and then saying, okay, this person is responsible for this adverse event. We all know that that person also suffers the consequences of an unanticipated adverse event. So this objective element has been highlighted, stating that the staff who is a second victim of an adverse event should be supported by the organizations. Then we are also aware of workplace violence. So in this case, separate objective element has been added that the organization should have measures in place for prevention and handling workplace violence. And it should be an integrative and participative approach. You must do workplace risk assessment, identify situations that are of special risk, work out the workplace interventions, including information and communication when the risk arises, have environmental interventions such as signages, security, restricted access, train individuals, like you train patient on patient safety, you must now start training employee on employee safety, and have liaison with the law enforcement agency so that if such an event happens, how it can be best handled and there are no cover-ups. Then the last chapter, the IMS 1H, keeping in line with the digital health technology that is required to be given more emphasis and importance in the times to come. This particular objective element has been added to use digital health technology at the excellence level, and it is for improving efficiency and patient and employee safety, for which appropriate software can be used, which could be for registration, for billing, for pharmacy, for IP, for imaging, for lab, for OP records. Use of AI and data analytics is encouraged, and some examples have been given, like computerized patient order entry, clinical decision support systems, barcode medication, automated medication dispensing, telemedicine, virtual visits, telemonitoring, having patient portals, electronic incident reporting, electronic medical records, and patient data management systems. Then the IMS 5C, organization maintains the security of record and data information. Here, more emphasis on preventive measures like cyber attacks on EMR, because that has been reported in the past. In major institutions has been reported. So how to ensure security of physical records, how to protect your record data information against loss and destruction. Also, what to do for physical and electronic records. What are, in case of physical record data, there must be provisions stored in file in cabinets, or there must be adequate and appropriate firefighting equipment, and they must ensure that the patient confidential information in terms of lab reports are communicated through a very secure messaging platform. So these were the changes in the objective elements. We have said there were 2 new standards, 7 objective elements were partially modified, and 14 objective elements were newly introduced. Now certain clinical department indicators have been added department-wise. We know there are existing 32 indicators, 12 clinical, 6 infection control, 6 managerial, and 8 patient safety, addressing PSQ 3A, B, C, D. Now in PSQ 3A, clinical departmental indicators have been added. There are 18 overall, out of which 14 are mandatory and 4 are optional. I will briefly take you through these indicators. For cardiology or internal medicine, percentage of beta blocker prescription with a diagnosis of CHF with reduced EF, that is ejection fraction. All details have been given as an ancillary in the guidebook itself. Numerator, denominators, and the explanation of this indicator has been given there. Percentage of patients with myocardial infarction with door to balloon time of 90 minutes is achieved. Same thing for endocrinology and internal medicine. Percentage of hospitalized patients with hypoglycemia who achieve targeted blood sugar level. In gastroenterology, percentage of cases undergoing colonoscopy and are sedated. Obs and gynae, spontaneous perineal tear rate. Ophthalmology, post-op endophthalmitis rate. In respiratory medicine, percentage of COPD patient receiving COPD action plan at the time of discharge. Neurology, percentage of stroke patients in whom the door to needle time of 60 minutes is achieved. Pediatrics, percentage of bronchiolitis patient treated inappropriately. Emergency medicine, time taken for triage. Sepsis management, percentage of sepsis patients who receive care as per R1 sepsis bundle. Nephrology, percentage of patients undergoing dialysis who are able to achieve target hemoglobin level. In oncology, percentage of onco patients who had treatment initiated following multidisciplinary meeting diet of tumor board. Nuclear medicine, percentage of adverse reaction to radiopharmaceutical. Radiology, percentage of intravenous contrast media extravasation. In biochemistry, percentage of point of care test results that led to a clinical intervention. In surgery, bile duct injury rate requiring operative intervention during lab cholecystectomy. And in rehabilitation medicine, functional gain following rehabilitation program. Now, these are the 18, out of which 14 are mandatory, 4 are optional. The departments have been encouraged to follow this at the start. Subsequently, when they achieve this, these indicators can be revisited and revised, and more can be added on as per the requirements of the clinical departments. Idea is to ensure the clinical departments also monitor their own workload and also monitor their own quality. Now, there are certain places where intent has been modified in each chapter. In AAC, intent has been modified to emphasize defining scope of care and addressing preventive and promotive services, which was a new objective element. In COP, they have added integration of healthcare delivery wherever multidisciplinary care is involved. In management of medication, they have included medical safety officer, reconciliation of medications at transition points and patient care areas. And in PRE, they emphasize on patient-reported experience measure and patient engagement to enhance clinical outcomes. In infection prevention and control, antibiotics have been replaced by antimicrobials. Obviously, the name of the chapter has been changed from HIC to IPC. In PSQ, emphasis has been laid on culture of safety involvement of clinical departments through capturing of clinical outcomes, and to address clinical governance and service continuity. And in HRM, better clarity on outsourced staff, volunteers, students, and trainees have been included in the intent modification of these chapters. I think in IMS, there have been no change, and in FMS, they have just made some language changes. Now, some other changes that have taken place: lab quality assurance and safety have been merged to prevent redundancy and simplify the content. That is, ASG 7 and 8 have been merged. In radio imaging, quality assurance and safety have also been merged for similar reasons. So ASC 10 and 11 of earlier standard have been merged, and ASC 11 has been introduced as a new standard. Some achievement levels have been converted to core or commitment, and some excellence level have been converted to achievement. There is no time to take and to give you all the details, but as an example, I will give you. For example, the earlier AAC 4E, that was the initial assessment for inpatient results in a documented care plan, has been reclassified from achievement to core. AAC 5C is for inpatient during reassessment. The care plan is monitored and modified where found necessary. This has been converted from achievement to commitment. AAC 12G, the organization monitors the discharge time, sets appropriate benchmarks, and makes continual improvement, has been changed from excellence to commitment. Now, this has been done to keep ourselves continually in compliance with ISCO requirements. The certain things cannot be compromised and they should be done immediately. Like documented career plan should be a part of the initial assessment itself. That is the final assessment. So therefore, we have to convert it from achievement to core. Like this, some of the achievements have come to core and commitment, some excellence has come to achievement, and some achievement have gone, and some gone down, some excellence have come to commitment. So doing all this, we have left with 13 short in excellence. Out of 30, we are left with only 17. Annexures have been provided. Annexures, some of the annexures contain some of the earlier elements, but they have been modified, like monitoring medication errors and clinical audits, risk management, examples of patient-reported experience measures and patient-reported outcome measures have been included in the annexures. Guidelines for disinfection and sterilization, including validation of tests by CSSD and the layout of CSSD, have also been given in this. And guidelines for implementation of antimicrobial stewardship program based upon the Ministry of Health and Family Welfare and our ICMR guidelines have also been included into the annexures. Of course, these are guidelines and you can modify based upon your requirements. This is the last change. So I think you will be relieved. You will be very much relieved that this is the last change, and this is a welcome change, because here it states feedback to be provided on your standards, objective elements, intent, scoring, interpretation, references, in assessment methodology, in language, on all the objective elements. This has been included in the guidebook on the Rumba principles of ISCOA. That means that all these elements of standards, objective elements you should tell us, give us, are they relevant based upon existing knowledge, principle, practices, protocols, and technology. If they are not relevant, please advise us. These can be removed in the subsequent revision. And if you think the new ones have to be added, please tell us. Ease of understanding of language and content. If there is some ambiguity, is a difficulty in understanding, or the content is inappropriate, this can be conveyed to the NABH on a regular basis. Now anybody can communicate. Amenability to be measured objectively. Is it being measured objectively? It's only subjectivity, and people are scoring based upon subjectivity. So please give suggestions to NABH so those objective elements can accordingly be modified in subsequent revision. Are they beneficial to the stakeholders? Is it beneficial? It's just being put for the sake of being put there because it is a contemporary requirement. So this feedback also will help NABH while they revise the subsequent edition, and whether they can be implemented or they cannot be implemented. Are they easily achievable or they are difficult to achieve? So if now in this guidebook, it has been very clearly given Please provide feedback by visiting Feedback Performer hosted on the NABH website www.nabh.co. So this is a welcome change because this will help NABH to improve its services by leaps and bounds, because every stakeholder will now know that through this portal they can reach out to NABH. So now the summary. So to summarize, the total number of objective elements have been reduced from 651 to 639. Core objective elements have been increased from 102 to 105. Excellence objective elements have been reduced from 30 to 17. Some changes are taken place in the classification of objective elements from achievement to commitment, from excellence to commitment, excellence to achievement. 2 new standards introduced for promotive and preventive health, that is AAC 11, and sustainability, that is ROM 3. 7 objective elements have been partially modified to include good practices in transfusion services, that is COP 8, B, C, and D, and to adhere to Ministry of Health and Family Welfare Guidelines, Lakshya Guidelines 2017 on safe obstetric services and addressing the requirements of assisted reproductive technology, that is COP 10, E, F, G, and K. 14 new objective elements have been added to address quality assurance of lab, that is ASC 7C, domiciliary care, that is ASC 12F, adolescence care, COP 11H, promoting patient engagement, PREFJ, appropriateness of clinical care, PSQ 2D, quality improvement project to focus on safety, sustainability, timeliness, effectiveness, efficiency, equity, patient and population centeredness, and clinical governance framework. Then security manual, management of non-fire emergencies, staff training on info and security systems, managing second victim of adverse events, on safety needs of staff in all shifts, on digital health technology, and on preventive measures against cyber attacks. So these are the 14 new objective elements that have been introduced. There are 18 department-specific indicators have been added. Detailed annexure includes risk management, patient-reported experience and outcome measures, medication monitoring, clinical audit, sterilization and disinfection guidelines, and guidelines for implementation of antimicrobial restoration program. Chapter on HIC has been renamed as IPC. Intent has been modified partially in 8 chapters. Reclassification of some objective elements has taken place. Shall replaces should, will, and would as mandatory requirement. Merging of lab and radio imaging quality assurance safety standards, and a separate provision for providing feedback by stakeholders. Now you'll probably ask me that why did I bring summary in the end? If I had spoken these 4 slides in the beginning, the whole talk would have been over. But that was just to elucidate the details of the changes that have been brought forward in this particular edition of NABH standards for hospitals. I must once again compliment the technical committee and NABH for taking out such a wonderful edition of 6th edition, which has not increased the burden on the healthcare organization, but which has further telescoped the requirements into achievable objective elements. And also, it has earned the appreciation of ISQA by not getting any recommendation on a standard. This happened for the first time that we have gone to ISQA for accreditation. So with all this, I come to an end. Thank you all very much for your patient hearing. I have taken my 45 minutes. Now we are open to whatever you want to suggest, and I can quietly probably stop sharing.
Thank you.
Over to
Thank
you,
you, sir.
Sunil.
Thank you very much, sir. You have elaborately explained all the changes which have been made. And I think going by the chat box, I think I can make out that you have attempted. Then there is one question, sir, which I would like to ask you from the chat box and from the Q&A aspects. Please, participants, please put it in the chat box so that easily it can be picked up. So one question is that could you again define STEEP, STEEP?
Okay, I already defined it twice, but I'll say again very easy. They are the dimensions of quality laid down by the World Health Organization. S stands for safety, that is patient safety. S also stands for, because this dimension has been amplified by WHO recently, that S stands not only for safety but also stands for sustainability. And both these things have been addressed in our standards.
Yes, sir.
T stands for timeliness of care. This has been adequately addressed by the fifth edition itself. But here we have added clinical departmental indicators, door to balloon time. All this has been included for this reason as a clinical indicator. So we have addressed timeliness. E stands for efficiency. So we added the financial sustainability to see your efficiency. Then another E stands for effectiveness. Whether so we have included we have given examples of patient reported outcome measures because that denotes the effectiveness of your clinical outcomes. Then we have also added, next one is on equity. Equity is unique, means that has been there from day one in NABH standards, that irrespective of the setting, the patient suffering will get the uniform care. This has been there from first standard edition of the standard itself. And last one is patient-centric. Needless to say, most of the things standards are patient-centric, but WHO has added another P to it. It should be people and population-centric. And that is where this particular standard which they have introduced in ASC 11 on preventive and promotive aspects of healthcare, that and on health education, that addresses this population-centric part. Okay, and therefore the quality improvement projects have to focus on these dimensions. So you know that if you have a quality improvement project, you must know that this is addressing these of the dimensions. It is giving a direction as to how you can reach there.
So I will take on a few more questions, sir, due to want of time. One of the question typically has been, I think, being asked again and again is, when are you implementing tracer methodology, patient tracer methodology, which is used by the JCI?
Okay.
I think you are the right person to answer
All
this
right.
question.
Yeah. Okay. See, since I do assessment for ISQA, ISQA is very clear. They give me tracers. They tell me this tracer methodology has to be followed. Now, NABH never debars you from doing a tracer. Okay. But yes, we need to, in the assessment methodology, we need to put it in the trainings of the assessor that you must follow. One of the methods is a tracer. We do brief in our assessor training program. And rather today only I took in the morning a session for the entry level assessors that you must follow a tracer methodology. So actually it is not banned that you will not follow. We should follow a tracer methodology wherever it is feasible. Where it is feasible, supposing you want to know whether the patient who is going for surgery, everything right from the time he is from the ward, he moves to the OT, what all is to be done as per the requirements of the surgical protocols. When he reaches the ward, what preparation has been done for the patient, how he is transported from the ward to the operation theatre, is it a safe transportation or not? Once he reaches the OT, there is a pre-operative evaluation, patient identification, the sign-in checklist has been checked or not. When he goes for surgery, the time-out checklist is being done or not. When he goes out of the surgery, the sign-out procedures are being done or not. The criteria for discharge from the post-operative area are being followed or not. What we call modified LD criteria. Has the instructions been given for the management in the ward or in the ICU? They have been recorded. So this is a tracer. You are tracing a patient and so many objective elements are being covered. Similarly, you can follow a sample. So this is one of the methodology by which you can actually see an entire gamut of systems that are being carried out on a particular element. When you do a tracer methodology, it takes a lot of time. And when you take a lot of time, the assessor's time. So therefore, we also, this is called a sort of a horizontal assessment. We have been teaching you in assessor methodology. So tracer methodology, more of a horizontal assessment. NABH does a lot of vertical assessment also to cover the most of the objective elements. So I think I'm clear on this. It does not ban, but maybe some assessors are not doing tracer methodology, but we are encouraging them to do tracer methodology wherever they feel there's a requirement to do that.
Yeah, some of the questions are they are hospital specific questions, but I will take the general questions like what is the qualification of medication safety officer, which is mentioned, and also what is the clinical governance framework which has been proposed.
Okay. See, medication safety, it is, I didn't know to actually elaborate on this. I would not like to be asked this question. Because medication safety officer can be one who has knowledge about medication.
Correct.
Who will have knowledge about medication is a person who is qualified, who is qualified or is qualified in pharmacology, or who has been administering or monitoring, who has been more deeply involved in dispensing, monitoring, or in administering the drugs, and who has knowledge about the drugs. Who will have knowledge? Either a clinical pharmacologist, or the knowledge can be on some very well-trained nurse, or the knowledge can be on a doctor. So these generally are the people who can be a medication safety officer, also a normal what we say, pharmacist who has got qualification and interest. So you find out who all can be in your organization who can serve this, who understand medication. So I think this is not a very difficult thing to do, but it can be preferably a clinical pharmacologist is the best person to be the medication safety officer. But NABH standard do not ban others from becoming a medication safety officer.
Yes.
What was the other one? Clinical governance framework.
Yes.
I think I've already elaborated upon that. The clinical governance framework focuses on clinical safety, focuses on clinical audits, focuses on clinical pathways, on clinical protocols. All this should cover are a part of a clinical governance framework, which we have been doing. But this addition to remove that confusion, they have put a separate objective element on clinical governance framework. Also, ISCO has now started making a very clear-cut difference between corporate governance and clinical governance. And therefore, we had to address this separately.
Yeah. I would also like to add here from the sir's statement, in clinical governance framework, we have also added now the utilization review, which is a not very old concept, I would say, but it has been revived again for improving the quality and safety purposes, which includes average length of stay, your appropriateness of investigations, appropriateness of the treatment. All these factors have been added into that. Another question which has been asked, sir, is typically on the clinical indicators. In pediatric hospital where there are not much departments, is it mandatory that the departmental indicators are applicable for us?
Okay, see, you can choose if it is not applicable, you can apprise that this particular indicator is not applicable for us. But in lieu of that, we are following another indicator, which is of use to you. Okay, because if you don't identify department-wise indicator, then departmental, the clinicians will not get involved in the process. The whole idea is to involve the clinicians. I think while making the departmental indicators, I think Colonel Rao, you must have undergone a lot of deliberations. You can share your experience on that.
Yes, yes. So there is always controversy regarding clinical indicators in terms of which department we should prefer. But in this particular departmental indicators, we have clearly specified about uh, uh, whether if it is in your scope of services, even in the pediatric department, pediatric hospital, if you have a cardiology which is included, then probably the scope includes the indicator which has been mentioned for cardiology department. Similar to that, many other hospitals, wherever there is a scopes, for example, we have kept some of them optional because we felt that they are little difficult. For example, gastroenterology, uh, for endoscopy, whether you require sedation or not require sedation, etc. So some of them have been purposely kept as an open indicator so that wherever possible, organizations should adopt those in the interest of the clinical quality. So that has been our experience. Various international standards have been taken into consideration while forming these indicators. Dr. Sanjeev Singh, Dr. Anand, and Dr. Lalu also, all of them have been participating in this process very actively, and I must thank them to come out with appropriate indicators for their specialty specifically.
Okay, no, Dr. Sunil, I also want to add here, you see this pediatric indicator, if you have got a pediatric, firstly, it should be in commensurate with the scope of service. If you have a pediatric department, this indicator was put in on percentage of bronchitis patients who are on inappropriate care. Because many people are using unnecessary antibiotics and unnecessary drugs for treating bronchiolitis. So this was put here to as an aid to our own antimicrobial stewardship program, that do not use unnecessary antibiotics when not indicated.
So I think with that, I think we'll end the session in terms of question and answers. I think most of the questions I have already addressed through Air Marshal Pawan Kapoor sir, and I would request Dr. Lalu to take over from here. Thank you very much for attending this session.
Thank you very much, sir. It's amazing session. I mean, the feedback, the chat box is full of excellent feedback about the session, and this is what we need to create the kind of awareness that is required in this country, and that's what KAHO is all about. Thank you once again. I have a couple of announcements. Number one, there will be an email sent to you from KAHO office. So using the link that is provided there, you will be able to download the certificate of participation for this excellent webinar. And number two, we have a couple of programs lined up for you. One is the masterclass series. I KAHO team to kindly share the flyer. We have the masterclass series on NABH standards. Can you please share the NABH one, please? We are starting the migration from NABH 5th edition to 6th edition. It's starting on the 1st of March. So every week you have 2 chapters covered. So if you look at the schedule, on the 1st of March, we start with the Access Assessment and Continuity of Care by Dr. Narayan Pense. We've got excellent faculty from across the country who will be handling these sessions, 1.5 hours session. So by end of March, rather beginning of April, you will be through with all the 10 chapters. So 1.5 to 2 hours of sessions per chapter with lots and lots of exercises clarifying all your doubts. So this flyer will also be circulated to you. Kindly register at the earliest because we have very limited slots for this particular masterclass series. Can you put up the, how do they register? Can you show the registration? Yeah. Scroll down. Yeah. So we have the who's who of accreditation who will be handling the quality and patient safety, who will be handling the sessions. We have a lot of inquiries from Sri Lanka, Nepal, Bangladesh, the other countries who have adopted the NABH standards as well. So for non-members, the 10 masterclass series, we are charging 4,000 rupees, and for members, it is 3,500. Lifetime members, again, it is 3,500 INR. We also have a JC Masterclass series that's starting on the 24th. 14 chapters of the Joint Commission International. This is particularly for those hospitals that are JC accredited and for those that are embarking on this journey of JC accreditation. So we have got 7 international faculty and about 7 our own faculty who have implemented the standards in this country. And again, I'm sure it's going to be a very, very interactive session. If you have not registered for this JCA Masterclass, you may do so because 24th of January, which is coming Friday, we are starting this. So, dear participants, thank you very much for joining. Both the flyers will be shared by email with you and also the certificate. A humble request to Pawan sir, can we go ahead and send the PowerPoint presentation to them, because I saw about 200 plus people sharing their email ID and asking you for the presentation.
Okay, I will send them. I'll send the presentation to you.
Thank you.
I have only one request, that when you improve this presentation, please send it back to me.
That's amazing. And that's a true leader. Thank you. Thank you so much. Thanks, dear participants. A big round of applause to Pawan Kapoor sir for his time, for all the efforts that he's put in and has made it so simple and nice. I don't know how he keeps all these numbers it's like in his fingertips, you know, he just talks about it just like that. Thank you so much, sir. And thank you, Sunil, sir, for the amazing leadership. We really look up to you. And thanks for sparing your time, and all the governing committee members of KAHO for joining us, and for all the participants. Participants, you don't have to share your email ID. We have it with us because you've registered for the webinar, and all of you will be getting the presentation and the flyers. Thank you once again. Have a
Thank
great
you.
Bye-bye.
Thank you all of you. Thank you for being patient participants. You did not ask me very troublesome questions, so thank you for that also.